Good evening. Am I audible? Okay. So please, let's start. I'm asking you not to write down your names into the chat because I see the list of all of your names. So you can use the chat if you have any questions, and I will try to answer. So today is our fourth lecture, and we will talk about functional anatomy of the skull. Previous lecture was dedicated to osteology. So we will talk about development, age-specific, sexual, and individual features of human skull. Okay, so first of all, what is it, the skull? Yes, skull, in Latin it is cranium. It is a complex of bones solidly united by sutures. So actually with some groups we have already reached the joints, and we know that bones of the skull are connected not only by sutures. Yes, there is also one synovial joint, that is temporomandibular joint, and there are also synchondroses. Yes, but the largest amount of connections of skull bones, these are sutures. Yes, indeed. Okay, so cavities of the skull contain the brain. Yes, the largest cranial cavity contains brain. Then sense organs are also located in the cranial cavity. So ear, yes, eyeball, tongue that has taste papillae, and so on. Nasal cavity with olfactory receptors. So sense organs are located in the cavities of the skull. Proximal parts of digestive and respiratory systems are also located in the cranial cavity. These are nasal cavity and oral cavity. Yes, so these two cavities are also located in the skull. So, and that's why we will later see, we have actually told about it at our practical classes, most part of the skull bones, they are flat bones, because the main function of flat bones, it is protection. All of these organs, they are very important for us. Yes, they are vital organs, brain, especially brain, yes. And that's why majority of skull bones are flat bones, but also there are pneumatic. We will talk about it. So this picture you have already seen at the lecture about embryogenesis and at the previous lecture about osteology. And now again, I want to remind you that all the bone tissue is developed from the middle embryonic layer, that is mesoderm. At the previous lecture, we were saying that, to be more precise, bone cells, osteoblasts, and then osteocytes, they are developed from mesenchyme. Mesenchymal cells, they are derivatives of middle embryonic layer, mesoderm. And also at the previous lecture, if you remember, that was last week, we said that, for example, a vertebral column is developed from paraxial mesoderm. Yes, skull bones, they are developed from mesoderm surrounding the brain. Then bones of upper and lower limbs, they are developed from somites. So if to be more precise about development of the skull, we first of all have to know that all the skull bones, and we also discussed it at our practical classes, are divided into bones of cerebral skull or neurocranium. So bones of cerebral skull, they form cranial cavity to surround and protect the brain. And there are bones of facial skull or viscerocranium. They form our face. Yes, they are smaller bones. And if bones of neurocranium are connected with each other with serrate sutures and squamous sutures, here bones of viscerocranium, bones of facial skull, they are connected with each other by plane sutures. Yes, sutura plana. And they are more cosmetic, but they are not so much reliable, as they are not so much firm, yes, than in comparison with squamous sutures and serrate sutures. So development of bones of neurocranium and viscerocranium is different. So neurocranium, bones of neurocranium, they develop from mesoderm surrounding the brain. These are first 4 cephalic somites. And bones of viscerocranium develop from the mesenchyme. So these are mesenchyme is a ventral, non-segmented part of the mesoderm. So they develop from pharyngeal arches. So please, I'm asking you not to press the button, go on ear, because today I am on ear. You will have an opportunity to share all of your knowledge with your teachers and with your group mates during your practical classes. And today I will speak. If you have any questions, once again, I'm telling you, you can write down your questions in the chat. And I'm asking you once again not to write down your names in the chat because I don't need it. I see that right now 82 students are present at the lecture and only 96% are active. For example, Abhishek Yadav is inactive. It means he switched on the lecture, but after that he opened another page and now he is watching some movies of Netflix probably. Yes? And who else? Sumit Kushwa, yes, he is also inactive. Tasnim Hussein is inactive. So all of them decided that lecture is very boring and they just above my page opened another page. So you see, I have all the information. You shouldn't write down your names. I can see what each of you is doing. Okay, that is development. So also at the previous lecture, we were discussing questions of osteogenesis, so formation of the bone tissue, and ossification. And we were saying that there are 2 types of ossification. There is endochondral and intermembranous types of ossification, if you remember. So in case of intermembranous ossification, bone cells are formed directly from the mesenchymal cells. So mesenchymal cells, then osteoblasts, then osteocytes. In case of endochondral ossification, bones are formed through the transitional stage, through the cartilaginous stage. So in this case, mesenchymal cells, they first form connective tissue model, and then so mesenchymal cells for cartilaginous model, and then cartilage is substituted by bony tissue. So for neurocranium, especially for bones of cranial base, endochondral type of ossification is specific. Yes. So first it is membranous stage, desmocranium, when skull consists of connective tissue, and such a stage lasts from the 2nd up to the 6th week of embryonic development. Then cartilaginous stage, chondrocranium. It lasts for 2 weeks only during 7th and 8th weeks of embryonic development. And it is only specific, yes, I want to emphasize that it is specific for only bones of cranial base. And bony stage of the neurocranium development lasts from the 9th week of embryonic development up to 20 to 25 years. Yes, so after the 25 years, growth of skull bones, any changes, they are completed and nothing new happens. Okay. Yes, so that's what we're talking about. 2 ways of ossification, just to remind you. There is intermembranous ossification, that is direct conversion of mesenchymal tissue into the bone, and it occurs in bones of cranial vault and also viscerocranium. And endochondral type of ossification, it is indirect conversion. So mesenchymal cells form cartilage and cartilage forms bone. It occurs in the bones of cranial base. And yes, I promised you that at this lecture, I will remind you again about types of ossification. So if you have any technical difficulties, if you don't see the presentation, you just should refresh the page and then you will see presentation, I'm sure. So intramembranous ossification first. I told you that first mesenchymal cells, which are developed from the mesoderm, they condense in a single place and they form ossification center. So these mesenchymal cells, they first get converted into the osteoblasts. And these osteoblasts start to secrete organic extracellular matrix. This organic extracellular matrix, it attracts, it can bond calcium. So calcium, you can see second stage, calcium and other mineral salts are deposited inside this extracellular matrix. And this extracellular matrix calcifies, it becomes hard. And when all the extracellular matrix that surrounds osteoblasts, it gets calcified, osteoblasts, they get transformed into osteocytes. And osteocytes, you can see, they are have like these processes, outgrowth, yes, and they are connected with each other, and they form like network, yes. And this network, the next stage, it is formation of trabeculae. Extracellular matrix that surrounds the osteocytes, it develops into trabeculae that fuse to form spongy bone. And so this extracellular matrix and osteocytes, they are located in the middle of the bone. But on the periphery, still there is periosteum. And periosteum, we were telling about it at the previous lecture, it is the main source of osteoblasts in the bone. Yes, due to the presence of periosteum, bones, they can increase their width because new osteoblasts go inward and they again secrete extracellular matrix, and it again attracts calcium, yes, and that's how bone becomes thicker and thicker. So once again, I'm telling you, if you do not see presentation, refresh the page. Once again, I'm telling you, do not write your names into the chat because it distracts me. As you see, I'm reading each message in the chat, yes? And your names distract me. And I can skip something really important. Yes, so please. I see that there is complete understanding between us. I'm asking, you are doing. Thank you. Thank you. Okay, so that is the process of intramembranous ossification. Endochondral ossification is slightly different process. Yes. So first, mesenchymal cells are again condensed into a common model. Yes, into the primary model, and then these mesenchymal cells, they get transformed into chondroblasts, and chondroblasts produce also extracellular matrix, and with the time they become chondrocytes. And chondrocytes in the middle of the bone, they start to proliferate rapidly because capillaries come here, vessels come here into the bone, and oxygen and nutrients are delivered. And with the presence of oxygen and nutrients, they begin to proliferate rapidly. They become hypertrophic chondrocytes, and finally they die. And with the bloodstream, with the blood, here osteoblasts come into this empty space where chondrocytes used to be. And osteoblasts, they, with the time, become osteocytes. So first mesenchymal cells, then chondroblasts and chondrocytes, and then osteoblasts and osteocytes. And these chondrocytes, they are, how should I say, they are moved, they are displaced towards the epiphysis, towards the metaphysis and epiphysis of the bone. And they, in the bone of adult person, not adult, but young person, let's say so, these chondrocytes, they stay only in the epiphyseal growth plate. Only in the epiphyseal growth plate and epiphyseal, and in the periosteum certainly. So epiphyseal growth plate, it provides growth of the bone into the length. Yes, periosteum provides growth of the bone into the width. Okay, osteoprogenitor cell, we were already talking about it at the previous lecture. It is such a cell, non-differentiated cell, bony, yes, which will later become osteoblasts, or it can come osteoclast, whatever, just non-differentiated cell, like ancestor of osteoblasts, osteoclasts, and osteocytes, these cells, primary cell. Okay. So viscera cranium, as well as cranial vault, it is developed by means of intramembranous ossification. So we said directly from mesenchymal cells, bony model is formed. And these first four cephalic somites, they later form pharyngeal arches. Pharyngeal arches. So first pharyngeal arch, for example, forms bones, eosicles, and also palatine bone, zygomatic, maxilla, and mandible. Second pharyngeal arch forms a styloid process of temporal bone and upper part of hyoid bone. Third pharyngeal arch forms lower half and greater horns of hyoid bone. Fourth pharyngeal arch forms thyroid and epiglottic cartilages of larynx. And sixth forms cricoid, arytenoid, and corniculate cartilages of larynx. So it will be important for us when we study nervous system, because different bones, according to their origin, will receive nerve supply from different nerves. Because first pharyngeal arch, for example, will give origin to the trigeminal nerve. So that's why tensor tympani muscle that is insert to the malleus, yes, it will be supplied by trigeminal nerve. And stapedius muscle that is attached to the stapes, for example, it will be supplied by facial nerve, because facial nerve is also derivative of the second pharyngeal arch. Okay. So what are the peculiarities of the structure of skull bones? What is the difference between bones of the trunk, upper limbs, lower limbs, and bones of skull? So first of all, it is lamellar structure of flat bones and presence of diploia. Diploia, we'll see it later, it is a layer of spongy bone between two layers of compact bone. Then intramembranous ossification of cranial vault bones, we have already said about it. Presence of paranasal sinuses, that's why we were saying that some cranial bones, they are pneumatic, yes, because they contain paranasal sinuses, and also presence of buttresses. So first, what is a diploia? Bones of cranial vault, squamous parts of these bones, they contain diploia. The structure of such bones is like lamellar structure. There is first external table or external plate that is formed by compact bone. And you remember that morphofunctional unit of the compact bone tissue, it is osteon or Haversian system, yes? Then the next layer, it is spongy bone or diploia, or spongy bone, yes. And then another layer of compact bone, it is internal table. Internal table is also named lamina vitrea, glassy plate, because external table is thicker than internal table. Internal table is thin. So sometimes during any fractures, any traumas of the head, of the bones of cranial vault, yes, we can not see any injury of the external table, yes, but because lamina vitrea or internal table, it is thinner, so it's more fragile. Sometimes fracture of internal table will not be accompanied by fractures in the external table, and we cannot notice it. That's why in case of any traumas in the head region, X-ray is compulsory, or it's better even CT scan. Yes, CT scan is more preferable to check the integrity of this lamina vitrea. So PDFs of these lectures are always available in our chat in VK. I think I also told you about it at the previous lecture and 1 week before. So every week I'm telling you that. Okay. The next, yes, pneumatic bones. So pneumatic bones are those bones which contain paranasal sinus, not a compulsory paranasal, but contain ear-filled cavities. Most of them communicate with nasal cavity, and that's why they are named paranasal sinuses. Para means around, nasal means nose, yes, so sinuses which are located near the nose. Near the nose. Okay, and so the pneumatic bones of the skull, they are frontal because it contains frontal sinus, ethmoid bone because it contains ethmoid ear cells, sphenoid bone, it contains sphenoid sinus, temporal bone, it contains sinuses like ear cells in the mastoid process. The largest of them, it is mastoid antrum. These are not paranasal sinuses. It opens into the tympanic cavity, but still it is also air-filled cavity. So you should know it. What is the function of paranasal sinuses? So functions of sinus are, yes, maxilla is certainly also pneumatic bone because it contains maxillary sinus. Yes. So functions of sinuses. First, the sinuses, they decrease the relative weight of the skull bones because if in place of the sinuses there would be bony tissue, then weight of skull bones would be increased. Yes, would be more than it is now. And so because our head occupies the highest position of our body during most part of the day, so that's why we need to decrease weight of skull bones to decrease the load onto underlying parts, like underlying vertebrae, onto the vertebral column. So the other function, it is increasing resonance of the voice. Yes, resonance of the voice gets increased because like sound wave, it gets reflected from the walls of the sinuses. Yes, when person suffers from inflammation of the sinuses, sinusitis, yes, these sinuses are filled in with liquid, inflammatory liquid, exudate, let's say so, yes, exudate. And voice of such a person gets changed. So we can easily feel that person is sick because his voice changes. So they also provide a buffer against facial trauma. They humidify and heating of inhaled air because, yes, now I know with you we haven't studied it yet, but with some groups we studied respiratory system, and air, it enters nasal cavity first, but because paranasal sinuses communicate with nasal cavity, also air enters them, and they serve as additional reservoir of the air. And while air passes through paranasal sinuses, it spends there some additional time. During this time, additional humidification and additional heating of the air happens. So because about resonance function, yes, of the sinuses, because sinuses in normal cases are filled in with an air, a sound wave, a sound is a wave, yes, it also enters the sinuses, it gets reflected from the walls of the sinuses, and it increases resonance of the voice. Like, there are rooms where sound spreads well, and there are rooms where sound doesn't spread at all. So the sinuses improve, increase resonance of our voice. It sounds louder, it sounds somehow brighter due to the presence of sinuses. And also immunological defense, because all the sinuses are aligned with mucosa, and certainly mucosa contains also immune cells and produces mucus, and it also protects us against any foreign microorganisms. Okay, so these are the functions. What are the buttresses? So buttresses are bony thickenings of facial skull. Buttress system absorbs and transmits forces applied to the facial skeleton. Masticatory forces are transmitted to the skull base primarily through the vertical buttresses, which are joined and additionally supported by the horizontal buttresses. So these buttresses, like columns, yes, they support human skull, yes. So they act as columns in the building, like they connect lower parts with upper part, and due to the presence of buttresses, upper part cannot compress the lower part. Yes. Yes. So first, which buttresses are distinguished? There is frontonasal buttress that goes from the frontal bone, frontal process of the maxilla and nasal bone. There is alveolar zygomatic buttress that goes from alveolar process of maxilla to the zygomatic bone. Here we can see it. Pterygopalatine that goes from the pterygoid process of sphenoid bone to the palatine, to the perpendicular plate of palatine bone. Palatine, alveolar that goes, it is horizontal, yes, that goes parallel to the alveolar arch of the mandible, and ascending buttress. So, yes, that's it. Yes, buttresses are present only in the facial skull. That is true. Okay, so skull, in Latin it is cranium, we said, in Greek cranion. And as you have already got to know, it is divided into cerebral skull, cranium cerebrale, or neurocranium, and facial skull, cranium viscerale, or viscera cranium. That's what we have already said. Neurocranium, in its turn, is divided into two more parts. A lower part is named cranial base, basicranium, here we can see it, and upper part is named cranial vault or calvaria, skull cap. That's it. What we have to know very well, we have to know points through which boundary border between cranial vault and cranial base passes. So first, it starts from external occipital protuberance, goes along superior nuchal line, passes above the base of the mastoid process, above the external acoustic meatus, through the base of the zygomatic process of the temporal bone, then infratemporal crest. What else? Then it goes upward along the frontal process of zygomatic bone, supraorbital margin, and then it comes up to the glabella. And then it goes to the other side through the same structures. Yes, so that's what you have to memorize. Okay, so cranial vault, bones of cranial vault, everything that is above this line, that is cranial vault, and that is below this line, it is cranial base. So cranial vault is formed by squamous part of frontal bone, parietal bones, squamous part of occipital bone, and squamous part of temporal bone and greater wing of sphenoid bone. All of these bones of cranial vault are connected with each other by means of sutures. Here we can see that between frontal bone anteriorly and two parietal bones posteriorly, There is coronal suture, sutura coronalia, between adjacent parietal bones, like an arrow. Sagittal suture passes, sutura sagittalis. Between occipital bone and parietal bones, lambdoid suture passes, sutura lambdoidea. So it has such a name because it has the shape of lambda letter. And between a squamous part of the temporal bone and also greater wing of sphenoid bone anteriorly, parietal bone in the middle, and occipital bone posteriorly, squamous suture passes. So all the previous sutures, they are serrate sutures, they are teeth-like, yes, teeth-like projections of one bone. They pass between teeth-like projections of another bone, yes. And squamous suture is another type. It is squamous suture. It is like fish scale, like margins of both bones which join each other. It's thin, they are thin, and one margin like lies on the other margin, like a fish scale. So it is squamous suture. Squama means scale, yes. So in the cranial base can be, it's not can be, but cranial base can be observed from outside, and it is external cranial base or norma basalis, yes, and also internal cranial base from inside, it is internal cranial base, yes. So external cranial base, when we describe it, we first of all should say that anteriorly it is closed by bones of facial skull, by cut palate, yes, here we can see. Posteriorly, we can see cranial base, yes, external cranial base. And here you should describe all the foramina which are visible here, like foramen magnum and so on. So, yes, that's it. Location of each of the foramina and its purpose, so what exactly passes through it. If we have time, we will discuss at the end of the lecture. So internal cranial base is divided into three cranial fossae: anterior, middle, and posterior cranial fossa. You have to know formation of each of the cranial fossa, boundaries, yes, and communications. So first, anterior cranial fossa. Posteriorly, it is separated from the middle cranial fossa by posterior margins of lesser wings of sphenoid bone and tuberculum sella in the middle. This is in the middle, it is tuberculum sella. Here we can see. Everything that is in front, it is anterior cranial fossa. Anterior cranial fossa is the most superficial, and it is formed by orbital parts of frontal bone, then cribriform plates of ethmoid bone, and lesser wings of sphenoid bone. Okay, there is the only communication of anterior cranial fossa through the foramina in the cribriform plate of an ethmoid bone. It communicates with nasal cavity. No, first with ethmoid ear, yes, with nasal cavity, yes, because olfactory nerve pass through it to the nasal cavity. Middle cranial fossa, fossa cranii media. Anteriorly, it is separated from anterior cranial fossa. What is the boundary? We have already mentioned, yes. And posteriorly, it is separated from posterior cranial fossa by superior border of the petrous part of the temporal bone, and in the middle it is dorsum sella. So middle cranial fossa is formed by superior surface of the body of sphenoid bone and cerebral surface of the greater wings of sphenoid bone, anterior surface of the petrous part of temporal bone, and some part of squamous part of the temporal bone. That's it. So communications of the middle cranial fossa are the following. First of all, there is optic canal that passes in the base of the lesser wings of sphenoid bone, and it leads to the orbit. Through the optic canal, optic nerve passes. Then, here we cannot see it, but between lesser wings of sphenoid bone and greater wings of sphenoid bone, superior orbital fissure passes. Yes, is located between. And through the superior orbital fissure, third, fourth, and sixth pairs of cranial nerves arise. They are responsible for movement of an eyeball. They are oculomotor, trochlear, and abducer nerve, as well as the first branch of trigeminal nerve, that is ophthalmic nerve. There is also foramen rotundum, through which second branch of trigeminal nerve leaves, it is maxillary nerve. Foramen ovale, through which third branch of trigeminal nerve leaves, it is mandibular nerve. And there is also foramen spinosum, through which middle meningeal artery passes. Middle meningeal artery. And so the deepest and the most posterior cranial fossa, it is posterior cranial fossa, yes. So anteriorly it is separated from middle cranial fossa by the line which we have already mentioned, and posteriorly we can make a boundary between posterior cranial fossa and cranial wall. It passes through internal occipital protuberance and groove for the transverse sinus. And so it is formed, posterior cranial fossa, by clivus, that is formed by fusion between body of sphenoid bone and basilar part of occipital bone, and also posterior surface of the petrous part of temporal bone, and squamous part of occipital bone, some part, low part, yes? And so the main communications of posterior cranial fossa are foramen magnum, the largest one, yes, through which spinal cord passes, or medulla oblongata. Here it continues to the spinal cord. There is also jugular foramen that is located between jugular notch of the occipital bone and jugular fossa of temporal bone, through which 9th, 10th, and 11th pairs of cranial nerves pass. They are glossopharyngeal, vagus, and accessory nerve, as well as internal jugular vein. Then here also there is internal acoustic meatus, through which vestibulocochlear nerve and a facial nerve leave cranial cavity. Okay. So if we look at the skull from the lateral side, then we will see norma lateralis, yes? And here from the lateral side we can see three more fossae. The largest, it is temporal fossa, fossa temporalis. Then the second one, it is infratemporal fossa, fossa infratemporalis. And the last one, the smallest one, it is pteryga palatine fossa, fossa pteryga palatina. So first, temporal fossa, fossa temporalis. It is located, like its inferior boundary is infratemporal crest of the greater wing of sphenoid bone, and it corresponds to the temporalis muscle. In this temporalis fossa, temporalis muscle is located. Superiorly, it is bounded by superior temporal line, linea temporalis superior. Yes, okay, that is temporal fossa. So temporal fossa communicates with infratemporal fossa, that is located below. Infratemporal fossa, its superior boundary is infratemporal crest of the greater wing of sphenoid bone. It has posterior and anterior walls. Posteriorly, it is lateral plate of the pterygoid process of the sphenoid bone. Anteriorly, it is maxillary tuber and the temporal surface, infratemporal surface of the maxilla, and that is all. So laterally, it is bounded by zygomatic arch. Infratemporal fossa has two communications. So through inferior orbital fissure, it communicates with an orbit. And through pterygomaxillary fissure, that is between pterygoid process of sphenoid bone and maxilla anteriorly, it communicates with pterygopalatine fossa. Pterygopalatine fossa, here it is lined with red. It is the deepest fossa. It is located medially from the infratemporal fossa, and it is bounded anteriorly by the maxillary tuber, posteriorly by the base of pterygoid process of sphenoid bone, medially by the perpendicular plate of the palatine bone. And this pterygopalatine fossa has 6 communications. Though it is very small, it has 6 communications. So first it is pterygomaxillary fissure that we have already told, yes, laterally it communicates with infratemporal fossa. Then inferior orbital fissure, through it communicates with an orbit. Then there is sphenopalatine foramen for communication with middle nasal cavity, to be more precise, with middle nasal meatus. Then pterygoid canal. Yes, through the pterygoid canal, pterygopalatine fossa communicates with external cranial base. There is greater palatine canal that is located inferiorly, and through this greater palatine canal it communicates with oral cavity. And foramen rotundum, which we have already seen, through the foramen rotundum, pterygopalatine fossa communicates with middle cranial fossa. So that's it. Okay. So bones of facial skull, what can we say here? They are small, we said, yes. They are fragile, they are very thin. So they are mandible, maxilla, vomer, palatine bones, inferior nasal concha, nasal bone, zygomatic bone, and lacrimal bone. Yes, so these are bones of facial skull. So the whole region of face can be divided into upper face, where forehead and orbit belongs, yes. Then middle face, mid face, where nasal cavity is located, and lower face, where oral cavity is present. So in the upper face, in the upper part of the face, we can see orbits, and we should know walls and communications of the orbits. So orbits, we will have also discussed it at our practical classes. They have a shape of tetrahedral pyramid, and base of this pyramid is directed forward and laterally, and base, yes, and apex of the pyramid is directed backward and medially. It has 4 walls: superior, inferior, lateral, and medial walls. Superior wall is formed by orbital part of the frontal bone, and posteriorly these are lesser wings of sphenoid bone. Lateral wall is formed by orbital surface of the greater wing of sphenoid bone, orbital surface of the zygomatic bone, and zygomatic process of frontal bone, and frontal process of the zygomatic bone. That's it. Okay. Inferior surface, inferior wall, is formed by orbital surface of maxilla and also maxillary process, orbital surface of zygomatic, orbital surface of maxilla, orbital surface of zygomatic bone, and posteriorly it will be orbital process of the palatine bone. Here we can see it. And medial wall has the most complicated structure. It is formed anteriorly by the frontal process of maxilla, then it is lacrimal bone, then orbital plate of ethmoid bone, posteriorly it is body of sphenoid bone. So communications of the orbit are the following. In the apex of the orbit there is optic canal that leads to the middle cranial fossa. Then between superior and lateral walls there is superior orbital fissure that also leads to the middle cranial fossa. Between lateral and inferior walls there is inferior orbital fissure that leads to pterygopalatine and infratemporal fossa. And on the medial wall there are 2 more openings, anterior and posterior ethmoid foramina, that leads to ethmoid ear cells. That's it. So in the middle, there is, in the midface, there is nasal cavity. So nasal cavity has also 4 walls, 2 lateral, superior, and inferior wall. So here, medially, it's not a wall, it is a division, like serves for to separate one part of nasal cavity from another. It is nasal septum. nasal septum, right. Yes, there is no need to write your names. That is right. Thank you. So a nasal septum has two parts. Yes, cartilaginous part and bony part. Anteriorly, there is cartilaginous part that is presented by septal cartilage. And posteriorly, there is bony part that is formed by perpendicular plate of an ethmoid bone superiorly, and vomer also, and nasal spine, so vomer. Inferior wall of the nasal cavity is hard palate. Of bony nasal cavity, it is hard palate. And it is at the same time superior wall of the oral cavity. It is formed by horizontal plates of palatine bone posteriorly and a palatine process of maxilla anteriorly. And so superior wall is formed by cribriform plate of an ethmoid bone, as well as nasal bones, yes, and body of sphenoid bone. And so the most complicated structure in the walls of nasal cavity, it belongs to lateral wall. So here we can see perpendicular plate of palatine bone and ethmoid labyrinth of ethmoid bone with superior and middle nasal concha, and then there is inferior nasal concha, that is a separate bone, and there are nasal bones also. Yes, so that's it. You have to know structure, and you have to know that in the lateral wall, the superior nasal concha and superior middle and inferior nasal concha, they form nasal metasis, superior middle and inferior nasal metasis, and they serve they communicate with paranasal sinuses. You should know which paranasal sinus with which nasal meatus it communicates. Yes. Okay. So what can we say about structure of human skull? We can say that with an evolution, and you know that evolution lasts for many years, yes, thousands, millions years, yes, human skull underwent some changes. So first of all, if we compare this skull of our ancestors with skull of modern human, yes, Homo sapiens, we can see that sizes of neurocranium increased significantly, whereas sizes of viscerocranium, on the contrary, they were decreased, because brain was increased in the size, yes, and due to our brain, we invented some instruments, some tools, yes, like at least knife and fork, yes, and we learned to use a fire. So now we don't need such big teeth, such big jaws to bite, yes, we can cut everything into small pieces. So that's why our face became much smaller, like our, yes, face. But our brain increased, and that's why cranial cavity also increased its size. So there are two major reasons of human skull evolution. It is bipedalism, that is relocation of foramen magnum forward. Due to the bipedalism, foramen magnum was relocated forward in a more central position. And encephalization, it is an evolutionary tendency towards a larger brain. So because now we stand on two legs, to replace, somehow to displace gravity center of gravity, foramen magnum was slightly, yes, relocated into more central position. So these are two main changes which occurred. Okay. One more thing which we have to discuss, these are age-specific features of the skull. So I hope most of you have already been at our museum, and you saw the skull of the newborn, yes? And if to compare skull of the newborn with the skull of an adult person, certainly they are different. So what are the features of a skull of a newborn? First of all, neurocranium is 4 times, sorry, it is a mistake. Neurocranium is 4 times larger than viscerocranium. And in adult person, this ratio is equal 2 to 1. 2 to 1 only. So neurocranium doesn't grow so fast as viscerocranium does, yes, with an age. Then, alveolar processes of the mandible and maxilla have no teeth. Yes, obviously. Mandible is very low, and maxilla is underdeveloped. And the nasal cavity is also underdeveloped. Orbital openings are wide, and they have round shape. Mastoid process of temporal bone also is poorly developed. Actually, all the sinuses here, yes, it's also written, they are nearly underdeveloped. So there are absolutely no paranasal sinuses. That's why newborns cannot suffer from hemorrhagitis, for example, or frontitis. Yes, that's good. So frontal and parietal tubers are strongly pronounced, and the skull bones consist, just like all the other bones actually, consist of numerous bony fragments. Like frontal bone consists of 2 parts, yes, and so on. Bones are flexible, thin, and smooth, and diploia is almost absent in skull cap bones. And so, yes, I told you there are no paranasal sinuses. The largest difference, the most significant difference between structure of newborn skull and skull of an adult person, these are presence of fontanelles. Presence of fontanelles. There are 6 fontanelles we have also discussed. What is diploia? Diploia we have already discussed what is it at the beginning of the lecture. It is spongy bone between external and internal tables, yes, of compact bone. It is present in the bones of cranial vault. So between external and internal tables, there is diploia. It is spongy bone. Yes. And so in newborns, it is nearly absent, yes, almost absent in bones of a cranial vault. So there is no diploia, there is just external and internal tables of compact bone. Okay, so totally there are 6 fontanelles. Anterior fontanelle and posterior fontanelle, they are unpaired. Anterior fontanelle, that is located between 2 halves of frontal bone and 2 parietal bones. It can also be named major fontanelle or rhomboid fontanelle. Posterior fontanelle, that is located between occipital bone and 2 parietal bones. It is unpaired also, and it is minor fontanelle or triangular fontanelle. And there is also sphenoid fontanelle, paired, that is located into point of pterion. Yes, this is, by the way, this point is named bregma. Yes, this is lambda, this is pterion. Yes, and mastoid fontanelle, it is also paired. It is located in the point asterion. Yes, as far as I remember. Okay. So sphenoid, and we know that these fontanelles, they serve for easier passage of fetal head through the female pelvis, because head is the largest part in the fetus, and if the head passes, then all the other parts of the fetus, they will also pass. Yes, this point is named asterion. I have just checked it. Yes. Okay. So sphenoid and mastoid fontanelles, they overgrow with connective tissue. They become sutures on the 2nd week of life. Then posterior fontanelle overgrows with connective tissue on the 2nd month of life. And anterior fontanelle, frontal fontanelle, it overgrows with connective tissue on the 2nd year of life. That's why in small children, if you palpate here, yes, in the region of anterior fontanelle, you can feel something soft. Yes, it's not bone yet. It will become bone later, on the 2nd year of life. We also have to know sexual features of the skull. Yes, what is the difference between male and female skulls? So first of all, it is capacity of the skull is in males it is slightly larger. So it is 1,450 centimeters cube in males against 1,300 centimeters cube in females. It is due to the common difference, general difference in sizes of males and females. Males are usually larger than females, yes, and it doesn't anyhow affect certainly intellectual abilities. So tuberosities of skull are more pronounced in males and less pronounced in females. I don't know what to do. Can the other hear me clearly or not? Okay, fine. So, okay, orbits are quadrangular in males and they are round shape in females. And certainly bones are a little bit thicker in males, and pneumatic sinuses are bigger in volume, and in females they are lesser in volume. So now I want to show you a video regarding growth and development of human skull. So please take a look.
The craniofacial skeleton is a complex structure. At birth, the human skull consists of approximately 41 separate bones. Craniofacial growth can only be fully appreciated by understanding how the growth of these individual components contributes to the development of the skull as a whole. There is a delicate balance between growth and remodeling that is influenced by and ultimately reflects sex and age differences in the skull. Such differences are used in fields like forensic anthropology and bioarchaeology to identify skeletal remains, examine the health of past populations, and understand human variation. At birth, the frontal bone consists of two bilaterally symmetrical halves. Within the first 8 months, the metopic suture fuses, forming a single frontal bone. To accommodate the rapid growth of the brain in the first 3 years, the frontal bone becomes more arched. As this growth slows, the forehead becomes less bulbous. Below the frontal bone are the orbits and the mid-face. In the maxilla, bone deposition occurs on the posterior surface of the maxillary tuberosity and the posterior and lateral surfaces of the zygomatic processes. Resorption occurs on the opposing surfaces. As a result, the maxillary tuberosity grows in a posterior direction, and the zygomatic arch grows posteriorly and laterally. The premaxilla exhibits downward growth. This directional growth is attributed to bone deposition on the inner surface and resorption on the outer surface just above the maxillary incisors. The lower face consists of the mandible and its teeth. Like the frontal bone, the mandible also starts out as two symmetrical halves. Fusion of the suture joins them into a single bone early in development. Main areas of bone deposition on the mandible are the posterior surfaces of the rami and the condyles. To maintain proportion while accommodating the lower teeth, resorption occurs on the anterior surfaces of the rami and at the angles of the mandible. The result is growth in a posterior and superior direction. From birth to the age of 16, the skull undergoes dramatic changes in size and proportions. The proportions in the adult skull directly reflect the timing and nature of facial skeletal growth. The cranium has nearly completed its growth at birth, and thus makes up a large proportion of the skull. As growth progresses, the size of the cranium stays relatively stable, while the facial skeleton expands rapidly in width, depth, and height. Individually, both the maxilla and mandible grow in a posterior and superior direction. But when placed in the context of the growing craniofacial complex, bone deposition at these locations displaces the middle and lower face downward and forward. Differences between the skulls of males and females are the result of a longer, more intense growth phase in males. As a result, male skulls tend to be larger and exhibit accentuated landmarks compared to female skulls. For example, the frontal eminences, supraorbital ridges, protrusive superior orbital rims, wider maxilla, and a more square and robust mandible. Although these features can aid in skeletal sex assessment, it is important to consider other factors that can also influence craniofacial growth, including individual and population variability. Understanding craniofacial skull growth and development makes it easier to predict and interpret variation observed in the adult skull. Patterns of growth can be used to determine the sex and age of a skull. Because the craniofacial skeleton develops as a unit, it is necessary to consider the ontogeny of the individual bones and their impact as part of the craniofacial growth complex.
That's it. So what else do we have to know? We all are different. We have already understood it. Yes. And but most of us correspond to norms. Yes. And we have also discussed that norm is not a very strict parameter. It is like a variety of norms. Yes, there are variants of norm. And for skull sizes, there is also a variety. Like there are several skull dimensions which can be measured by a special device that is named craniometer. That's it. It has two branches and a centimeter line from inside, from the base. Yes. And so we can measure longitudinal size of the skull and longitudinal size of the skull. On average, it comprises from 167 to 193 millimeters. Longitudinal size, it is from the external occipital protuberance up to the glabella. So here we can see this is longitudinal size. Transverse size is between the most prominent lateral parts, between two parietal tubers usually it is measured, and it is equal to 123 to 153 millimeters. Vertical size, that is from the uppermost, from the bregma up to the submental region, the lowermost point of the head. It is vertical size, and it is in average equal to 126 to 143 millimeters. So knowing all of these sizes, we can calculate cranial index that is equal to the relation, like a ratio. Yes, between transverse size and longitudinal size. So transverse size should be divided into the longitudinal size, and then we should multiply it to 100. And according to this cranial index, we can divide all the skulls into three types. There is dolichocrania, when cranial index is less than 75. Yes, when it is less than 75. It is dolichocrania, right? It is long and narrow skull. Then if cranial index is 75 to 80, then it is moderate skull or mesocrania. So yes, this longitudinal. Yes. And then if a cranial index is more than 80, then it is short and wide skull. It is brachycrania. Brachycrania. So these are three types. So yes, and the last part of our lecture, here we can say about openings of the skull and their purpose. So first I told you that in the anterior cranial fossa, there are openings in the cribriform plate of an ethmoid bone. And in it, olfactory nerves pass. These are first pair of cranial nerves. In the middle cranial fossa, there is optic canal through which optic nerve passes. It is second pair of cranial nerves, and also ophthalmic artery. Here we can see between lesser wings of sphenoid bone and greater wings of sphenoid bone, we can see superior orbital fissure, through which I have already told you oculomotor nerve passes, it is third pair, trochlear nerve fourth pair, abductor nerve sixth pair, and also first branch of the trigeminal nerve, it is ophthalmic nerve, and as well as superior ophthalmic vein. Inferior orbital fissure that is located between lateral and inferior walls of the orbit. It is a communication with infratemporal fossa and pterygopalatine fossa. Through the inferior orbital fissure, infraorbital artery, that is a branch of maxillary artery, and infraorbital nerve, that is a branch of maxillary nerve, pass. Foramen lacerum. Here it is also located in the middle cranial fossa. It is located in the place of contact of the meeting, let's say so, between basilar part of occipital bone, apex of petrous part of temporal bone, and body of sphenoid bone. So this foramen lacerum doesn't belong to any of the bones. Through it, internal carotid artery passes. So at the region of apex of petrous part of temporal bone, we have already said it. Internal opening of carotid canal located. Here we can see. In external opening is located at the inferior surface of the petrous part of temporal bone. So if carotid canal ends in the apex, then later, after that, it passes through the foramen lacerum to enter cranial cavity. So here we can see foramen rotundum or round foramen, through which maxillary nerve, that is the second branch of trigeminal nerve, passes. Slightly behind and laterally, there is oval foramen, foramen ovale, through which mandibular nerve, that is the third branch of trigeminal nerve, passes. And there is some even more laterally, there is spinous foramen, through which middle meningeal artery passes. All of these openings, they are openings of the middle cranial fossa. In the posterior cranial fossa, here there is internal acoustic meatus, through which facial nerve passes. It is the seventh pair of cranial nerves, and vestibulocochlear nerve, it is eighth pair of cranial nerves. Jugular foramen, that I have already told you, is formed by jugular notch of occipital bone and jugular fossa of temporal bone. Through it, glossopharyngeal nerve, the ninth pair, vagus nerve, 10th pair, and accessory nerve, that is 11th pair of cranial nerves, leave the cranial cavity, and also internal jugular vein. Internal jugular vein. Hypoglossal canal at the base of occipital condyles. Hypoglossal canal passes through which hypoglossal nerve leaves cranial cavity. It is 12th pair of cranial nerve. So foramen magnum, yes, the largest opening. It is place of the transition of medulla oblongata to the spinal cord. Also vertebral artery passes through it, and venous plexus. On the external cranial base, between styloid and mastoid processes of the temporal bone, stylomastoid foramen is located. Stylomastoid foramen is the final opening of the facial canal. So facial nerve leaves cranial cavity, starts its way from internal acoustic meatus, so it enters facial canal, and it forms some turns, yes, and facial canal ends in the stylomastoid foramen. Sphenopalatine foramen, it is an opening in the pterygopalatine fossa. Through it, sphenopalatine artery passes, that is a branch of maxillary artery, and also posterior, medial, and lateral nasal branches from pterygopalatine ganglion. This is sphenopalatine foramen. And greater palatine foramen, it is a communication between pterygopalatine fossa and oral cavity. Descending palatine artery, as well as greater palatine nerves, pass through it. Okay. So that's what I wanted to tell you for today. Do you have any questions? So if you have free time, yes, if you don't have classes at the time of, yes, of my lessons, certainly you can come and listen. You are always welcome. Yes, but you shouldn't have your classes at that time, because if you skip your classes, you will have problems with the other subjects, maybe with anatomy subject. Yes, so at your free time, please, you are always welcome to come for my lesson. So I guess now you are interested in the topics of the first semester. My first semester groups, they study on Friday and on Monday. So Monday from 8:20 and then 11:40, and Friday 8:20 and 10:30 also. So these are topics of the first semester. Yes, Monday and Friday. Monday and Friday from 8:20, one lesson, and another lesson at 11:40. Any other questions? Yes, right. Sense is the same. Yes, like in the bird, nearly all the bones are pneumatic. Yes, because they need to fly. Yes, they need to be very light. Yes, and in humans, pneumatic bones are only those which are in the skull. Yes, classes are running offline. No, spongy and pneumatic bones are not the same. First of all, spongy bone and compact bone, it is classification of bone tissue. So all the bones, it doesn't matter like what is their type, is short, long, flat, pneumatic. They consist of both compact bone tissue and spongy bone tissue. Yes, it is not the same. And pneumatic bones are those which contain air-filled cavities. So in these cavities, there is not bone tissue at all, even spongy bone. There is just empty space that is sinus. So it is not the same. Pneumatic bones are those which contain air, yes, inside, air-filled cavity. Yes, I will send you PDF into the chat in VK. Mm-hmm. So no more questions, yes? So if you have no more questions, then you may be free. See you next time. Thank you for your attention. Goodbye.